Thank you, Somani sir. Thank you, Dr. Lalit. I'm Dr. Raajit, working at Dharamshila Narayana. So I'll be discussing this study, that is PRODIGE 29 Neopan study, which is a phase 3 randomized trial comparing chemotherapy with Folirinox or Gemcitabine in locally advanced pancreatic cancer. So the slide sets are directly taken from ESMO 2020. So this was a French study led by Dr. M.P. Ducry. So please pardon my pronunciation. So background: pancreatic carcinoma, we know that it is an aggressive malignancy and it is the 4th leading cause of deaths worldwide. And more than 30% of the patients of pancreatic cancer, they are not resectable because of the local extension. And the median OS is dismal, less than 1 year. And we know that in metastatic setting, Folirinox is better than Gemcitabine in terms of OS and PFS, but the standard of care remains Gemcitabine for locally advanced pancreatic cancer. So coming to the definition of locally advanced pancreatic adenocarcinoma, it is based on arterial and venous infiltration. In terms of arterial, in pancreatic head or uncinate process, the solid tumor contact is more than 180 degree with the SMA or celiac axis. And pancreatic body or tail, the solid tumor contact is more than 180 degree with the SMA or celiac axis. And venous means that unresectable SMV or portal vein due to tumor involvement or occlusion. So the study design was 1:1 randomization of locally advanced pancreatic cancer with Folirinox and Gemcitabine. Folirinox was given for 12 cycles every 2 weekly. Gemcitabine was given 6 cycles of 4 weekly interval, and the primary objective was PFS, and secondary objectives were adverse events, overall survival, and objective response rate. Stratification factors were tumor location, investigator site, performance status, and less than and more than 60 years of age. Coming to the population description, the median age was 66 years in both the arms, and most of the patients were of good performance status. Head of the pancreas was present in around 57% in both the arms. Majority of the diagnoses were adenocarcinoma, only 1% were adenosquamous carcinoma. Superior mesenteric artery invasion was present in around 52% in Gemcitabine and 44% in Folirinox arm. Portal vein involvement was in 21% and 28% respectively. Biliary bypass was done in around 28% of the patients in both the arms. Coming to the results, the PFS results favored the Folirinox, that was 9.7 months as compared to 7.5 months. However, at the end of median follow-up of 41 months, the PFS did not translate into an overall survival benefit. So it was 15.6 months with the Gemcitabine and 15.1 with Folirinox. Tolerance was, as we know, that it was reasonably okay. Grade 1 side effects were present in almost all the patients, and the incidence of grade 3 or more side effects, they were present equally in both the arms. The incidence of grade 3 nausea was 5% in Gemcitabine along with vomiting. Incidence of neutropenia was 22% in Gemcitabine. So the hematological side effects were more in the Gemcitabine arm. In the Folirinox arm, nausea and vomiting grade 3 were present in 12 and 10% respectively, and neutropenia was present in 12%. The primary results were that coming to the second line treatment, the subsequent treatment before PD, chemotherapy was given in 33% in the Gemcitabine arm and 41% in the Folirinox arm, and radiation was given in 9% in the Gem arm and 15% in the Folirinox arm. Surgery was done in 3% in Gemcitabine arm and 4% in Folirinox arm. After progressive disease, around 48% and 62% patients received chemo in Gemcitabine and Folirinox arm, and radiation was given in 2 and 7% respectively. So I think I have missed one of the last slides. So what this study is trying to show that in LAPC, Gemcitabine remains one of the standard of care, and Folirinox has not resulted in better overall survival, although the PFS is more and the response is slightly more. So if we are planning for surgery and the patient is fit enough, then Folirinox, I think, should be used as a standard of care. But due to some reason, if patient is not fit, then Gemcitabine is also a very good option, which has demonstrated similar overall survival. So with this, I would like to conclude my presentation and thank you all for listening.
Respected chairpersons, because we are unfortunately not having the second presentation. So may I request all of you to make some comments and the expert comment based on the first discussion. Dr. Lalit.
So maybe I'll add something more, that Gem NAP paclitaxel would probably should be a better comparator arm. In this study only Gemcitabine was taken, but still it was able to show that Gemcitabine had resulted in similar OS. So but the PFS was more in Folirinox arm. So it has given us the option of using all three combinations in LAPC setting.
Dr. Tarachand, you would like to make comments, expert comments?
For nice, wonderful presentation on product. Has the compare the Folirinox, and that has the good results. I think it can be tried in the LAPC also. Yes, the toxicity is the major concern, but yes, if we are getting overall survival benefit, then it is worthwhile.
Dr. Lalit sir.